sir.
Okay?
Yes, sir. It's on fine.
Okay. Non cardiac morbidities, patient with rheumatoid arthritis on methotrexate and once a week. But now she came with 5 days of fever, subsided on treatment with antibiotic, and an episode of syncope after prolonged standing 2 days back, increasing exertional dyspnea and orthopnea. Tachycardia, surprisingly, she had pulsus paradoxus. Hypotension, AVP raised, mild penile edema, bilateral desk crepitations, abdomen soft with tender hepatomegaly. There's nothing to comment on. It's just X-ray, except probably you may say straightening of the left border of the heart. But this is a AP view, and you find there's a little rotation of the patient. And when you looked at the echocardiogram, what is important was not the fluid around the heart, but the pericardium. It was angry. It was angry and thickened, boggy. At times, there are some areas of thickening and marked abnormality of the pericardium. Pericarditis. That's what we found. And a very careful echo done with an M mode showed that the RV outflow tract was collapsing in diastole. Normally, RV outflow tract contracts in systole. Down in diastole. This is a sign of pericardial tamponade with a small effect. It's a certain high dose of and depth of 36 milligrams. Methotrexate is increased 10 milligrams weekly. What hospital day after treatment, RV diastolic collapse disappeared. Here, it's in systole. It's a normal contraction of the RV outflow tract in systole. And the effusion has disappeared. There's still some thickening of the pericardium, but not the very doggy pericardium that you found last time. And in 2 weeks' time, everything disappeared. Everything disappeared in 2 weeks' time. And a high dose of methotrexate and steroids. And what does this show? This shows that pericardium is a very much alive organ. It reacts to different diseases in many ways. It can become angry and it can become quiescent. Identifying the characteristic signs will help us to correctly diagnose the etiology. Never be carried away by the water there, by the pericardial effusion, and these will be the many changes in pericardial pathology. We have a very thick pericardium, very thick parietal pericardium, which is thick and fibrous. But the visceral pericardium is very thin and filmy, And normally the pericardial cavity will contain 20 to 50 ml of fluid. Respiratory variations of intrathoracic pressure transmitted to the pericardium always. And when the fluid accumulates, when the pericardial fluid accumulates, we have to differentiate the pericardial fluid from the pleural fluid. And if you find it's the pleural fluid, you find this is a pleural effusion. Pleural effusion occurs posteriorly, and the descending thoracic aorta will be in front of it. It's a pleural effusion with descending thoracic aorta in front of it. While if it's a pericardial effusion, the descending thoracic aorta must be out of it, and here is a pericardial effusion where the pericardial effusion is here. Descending thoracic aorta is totally out of it because it's in the where is it in the paravertebral gutter. So pleural effusion and pericardial effusion could be easily distinguished by looking at its pathology, looking at its location in relation to the effusion that you see. Pericardial effusion is separation of visceral and parietal layers of pericardium by excess fluid. You find this thin film of pericardial fluid in patients with even with cardiac failure, chronic congestive failure, and sometimes with acute pericarditis in many viral fevers, or It may be significantly larger. Here it's about 4.2 centimeters pericardial separation of visceral and parietal layers. Often it could be silent small effusion. Pericardial rub may be present, but it's always echo is diagnostic. Echo had been a boon to the clinician to diagnose pericardial fluid in a patient presenting you with chest pain, dyspnea, fatigue, and many such conditions. And the separation between parietal and visceral pericardium is only about a centimeter or less. It's about 100 ml of fluid in the pericardial cavity. 1 to 2 centimeters, I find about 100 to 500 ml. More than 2 centimeters, more than 500 ml. And it could be massive like this, with the heart floating and swinging within the pericardial cavity. Can you see this? It's swinging within the pericardial cavity. So there's a variability, and you can have a rough assessment of the quantity of pericardial effusion. Let us look at the tamponade. Pericardial effusion leading to high intrapericardial pressure. What is outside the heart, around surrounding the heart, the pressure is high, this cardiac compression. It's a reduced feeling of right and left heart chambers. Increase and equalization of intrapericardial, right heart, diastolic, and pulmonary capillary bed pressure. Decreased cardiac output because heart cannot fill, and the blood pressure. Increased heart rate and pulmonary vascular resistance. We have discussed what is mild, moderate, and large pericardial effusion and massive pericardial effusion. This is the right atrial pressure. This is the right atrial pressure. This is the intrapericardial pressure. When the intrapericardial pressure goes above the right atrial pressure, it presses on the right atrium, and right atrium could not fill. So cardiac filling is dampened, and is at this point of right atrial pressure, the intrapericardial pressure becoming more than the right atrial pressure, that you find tamponade occurring. So this is a clinical diagnosis. Patient in shock. High venous pressure, increasing on inspiration. Small pulse pressure, decreasing on inspiration. I always tell my students, this is paradox. Venous pressure and venous pulse, increasing on inspiration. Arterial pulse, decreasing on inspiration. Underlying pericardial disease. Accurate diagnosis requires integration of clinical, echo, and hemodynamic data. One of the signs you look for is a thinnest chamber which collapses by rising intrapericardial pressure. Look here. This is the left ventricle, right ventricle, left atrium, right atrium. In all my pictures, left will be on the left side, right on the right side. And look at what's happening to rising intrapericardial pressure, involuting, if we may call it even involution, collapse of the right atrium. When does the right atrium collapse? When the right atrial pressure is at the lowest. When is the right atrial pressure at the lowest? When the right atrium is relaxing. When does the right atrium relaxes? It relaxes during right atrial diastole, it is during ventricular systole. So this happens during ventricular systole. The atrial collapse happens in ventricular systole. Right atrial collapse, more than 1/3 of systole has a sensitivity of 94% and specificity of 100% for the diagnosis tamponade. A very specific sign. And this could be recorded in M mode. This particular patient actually has a collapse occurring throughout the cardiac cycle, the systolic diastolic. Every time it's collapsing, so the intrapericardial pressure was so high. Rarely is the left ventricle from the left side. You may find a little left atrial collapse also when the intrapericardial pressure goes above the left atrial pressure. This is a rare sign that you may find in patients with pericardial effusion. Next, thinnest part. After the right atrium, thinnest part is the right ventricle outflow. So As the pressure rises further, the right the pressure it prevents the discharge of the right ventricle outflow tract. Normally, the right ventricle outflow tract contracts in systole. Here, the right ventricle outflow tract has you see the vertical line is collapsing in diastole. This is an abnormal pathological phenomenon. A vertical line shows that RVOT is collapsing in diastole. Here is a patient, the first patient whom I mentioned. It collapsed diastole, and the patient recovered. RVOT contraction occurred, and what is called the RVOT contraction, not the RVOT collapse, occurs in systole, and that's a sign of recovery, reduction of intrapericardial pressure, as demonstrated by a good M mode. The whole heart is contracting within a high pressure pericardium. So here limited space for the heart to expand, and as you may find here, the heart in inspiration is decreasing venous return, the right ventricle dilates, the left ventricle becomes smaller. With expiration, the right ventricle becomes smaller, left ventricle dilates, which you can see to some extent in this particular 2D echo, and the full LV is visible only in expiration when it fills up in expiration. So reciprocal changes in ventricular volume during respiration is another sign of pericardial tamponade, and this is a right ventricle inspiration RV becomes larger, expiration LV becomes larger, and reciprocal changes is a sign of pericardial tamponade. This is because of the fixed pericardial space, as is shown here, and within the fixed pericardial space, only limited opportunities there for cardiac chambers, and when the right side dilates in inspiration, left side becomes smaller. When the left side dilates as an expiration, right side becomes smaller. Same thing can be seen in the tricuspid flow pattern. When you take a deep inspiration, there is a early diastolic E wave increase, early diastolic E wave increase in a sequential manner. You can see that sequential manner. RV early diastolic filling velocity is increased, and variation more than 40% in increasing filling velocity indicates tamponade. Tricuspid filling velocity more than 40% increase in inspiration indicates tamponade. On the other side, you may find same thing in the mitral valve. In expiration, the mitral flow increases. An increase of mitral early diastolic flow velocity of more than 25% in the filling velocity again indicates tamponade. So looking at the tricuspid flow velocity, it is more than 40% increase. That's a normal. Tricuspid filling velocity normally increases, but that increase hardly ever goes more than 20%. More than 40% is a variation of normal, pathological variation of normal. That's what indicates tamponade. Same thing with left ventricular filling velocity. More than 25% indicates tamponade. Reflection of the same thing is in pulsus paradox. Aortic velocity, inspiratory decrease in velocity of more than 50% indicates tamponade. And this is what you feel as pulsus paradoxus. If you look at the velocity here, remarkable variation in velocity, you can appreciate. But there are patients who have tamponade without pulsus paradoxus. Patients with pre-existing RV or LV failure and high-end diastolic pressure. Patients on positive pressure ventilation. Atrial septal defect, pressure equalization of both sides of the heart. Corpulmonary. RV infarction. Hypervolemia. Severe arterial regurgitation. These are conditions where, in spite of pulsus paradoxus, in spite of cardiac tamponade, you may not find pulsus paradoxus. Yeah, this is what shows the orbitodactyly collapse. And we are coming to, look here. This is not the outflow tract. This is the inflow tract, a free wall of the right ventricle. And you can have a diastolic collapse. Why diastole? The lowest pressure in the right ventricle is at the beginning of diastole. That's the time the high intrapericardial pressure can press on the right ventricle. And this is what really hampers, obstructs the filling of the right ventricle. Maximum filling of the right ventricle occurs at the early diastole. That's the time RV diastolic collapse occurs. Right ventricular pressure is at the lowest, the beginning of diastole. The high intrapericardial pressure can indent it. This may not happen if there is RVH or RV free wall infiltrated disease. This is less sensitive, 60-90%, but more specific, 85 to 100% than the RA collapse side. Invariably, in all these patients, you find the high right atrial pressure reflected on the inferior vena cava, dilated, non-collapsing inferior vena cava. This is a part and parcel of tamponade physiology. There are some pitfalls in these signs. High LV diastolic pressure with a pre-existing left ventricular failure, high RV diastolic pressure in pulmonary hypertension and RV failure. Signs of cardiac tamponade may not be obvious. Signs are not reliable in atrial fibrillation. A cycle and determines the pressure pattern. Hepatic flow pattern cannot be associated with 1/3 of the patients. Seeing the fluid there, don't jump in and put in the needle. There's an old Barcelona indications. Remember that tamponade has to be diagnosed in the ER, but in a patient with coming with shock, elevated JVP, pulsus paradoxus, think the tamponade, do an echo, and urgently you may have to remove from the fluids. Or if you require pericardial fluid for diagnostic examination, you may have to do a pericardial tamponade. There are related contraindications. Traumatic tamponade, perform thoracotomy instrument, myocardial rupture, aortic dissection, bleeding diathesis. You'll remember that during coronary angiogram, there's any perforation, the cardiologist immediately puts in a needle and removes the blood that is oozed out, so that the pericardium really helps you to prevent further bleeding. The usual method is, I always prefer subcostal. You can use the apical or even the left parasternal method to the pericardiosynthesis. There is a variety of so-called tamponade in a patient with severe diarrhea, vomiting, low end-diastolic pressure can be associated with right atrium, right ventricle, or rarely even LV diastolic collapse. There is no cardiac tamponade. It's hypovolemia, and hence I usually call it a Cheshire cat tamponade. There is no true cardiac tamponade, but with some signs of tamponade. Cheshire cat is the cat you find in the legendary Alice in Wonderland. But the cat is not there. Only the smile of the cat, the eyes of the cat, and some whiskers that are seen, and the cat is not there. Same way, there is no tamponade, but some tamponade signs that can be seen. Tamponade with small pericardial effusion can also occur. Cardiac surgery, coronary intervention, transeptal puncture, pacemaker wire perforation, CP line perforation, aortic dissection, and chest trauma. These are conditions where sudden accumulation of fluid can immediately produce a tamponade with a small pericardial effusion. Always remember, pericardial tamponade is a clinical diagnosis, and the patient comes in shock. High venous pressure, small pulse pressure, decreased immune inspiration, the underlying pericardial disease. Accurate diagnosis requires integration of clinical echo and hemodynamic data. And accurate diagnosis is so important to save a life. Let us look at some of the inflammatory disease. Acute pericarditis. This is not only related to pericardial effusion, but some myocarditis also, myopericarditis. The small effusion could be seen in many patients with at least about 10 to 20% of patients with common fevers like dengue and chikungunya. But this kind of myopericarditis is not that common. The common variety of acute myopericarditis can be diagnosed with history, physical findings, serious examination, chest X-ray, and echocardiogram. This is a classical finding: flask-shaped heart. So much of fluid is accumulated within the pericardial fluid. The flask-shaped cardiac pericardium. And in rare cases, the fluid could be so large that you may find a swinging heart within a pericardial cavity with so much of fluid around the heart. And this requires definitely putting in a needle and moving. But as I said earlier, never get lost in the pericardial fluid. Water is only one among the signs of pericardial. Always look at the pericardium. Is angry, boggy, some areas of thickening. All these indicates that it's not only the fluid collection, there is a specific pathology of the pericardium which should be described and acutely edema in the pericardium. Amorphous material in the pericardium indicating high fibrin and protein. Sometimes large pericardial effusion. Swinging of the heart and systolic collapse of the right atrium are signs that it should be removed. The swinging of the heart has nothing to do with the cardiac cycle. Some signs may be there in relation to respiration. There is nothing to do with the cardiac cycle. The acute myopericarditis or pericarditis, presentation of myocarditis, febrile illness, tachycardia, hypertension, often with involvement of the lungs, rapid progression symptoms with hemodynamic dislocation. Unless there is pericardial tamponade, and the effusion is massive, no indication to tap it. Rarely you may have to tap it for diagnostic purposes. And acute pericarditis, and I think I written here myopericarditis. Acute pericarditis can be treated with NSAIDs. If no response within about 5 days, corticosteroids. If no response within a week, colchicine. Or rarely, if it lasts longer, a therapeutic trial of antituberculous treatment may be required in some of these patients to decide on what is produces. The presence of amorphous material within the pericardial cavity definitely indicates that there is inflammation and tenuity. Look in this particular patient. There is a mild mitral stenosis. Can you see that? Little inflammatory prolapse of the postmitral leaflet. This is now not so common acute rheumatic myocarditis and pericarditis. Because of the presence of mitral valve pathology, we can say that this is an acute rheumatic pericarditis with myocarditis, and the ESR was about 80, AS was high, and this patient was treated with steroids and salicylate and did very well. Essentially, similar changes may be seen. Look at this other patient. Similar changes may be seen in all patients with discolaginosis with some peculiarity. This is a patient with systemic lupus erythematosus. Please remember, pericardial pathology is not uncommon in discolaginosis. And discolaginosis is not uncommon in our community, in especially middle-aged patients. And this is what you have to look for. Is there pericardial involvement? There's a patient who came, 42-year-old lady came with mild cardiac failure. She had skin changes over both hands and face, and some treatment from the medicine department. Clinically, she had minimal features of heart failure, but she felt always tired. Look at this picture. There's so much of right ventricular enlargement. Right ventricle is markedly dilated, pressing on the intraventricular septum and indicating very high right ventricular pressure. Severe pulmonary hypertension. Severe pulmonary hypertension. Parasternal window. And if tricuspid regurgitation velocity was very high, with a calculated pressure gradient of 66 millimeters of mercury, this patient obviously has severe pulmonary hypertension. And this patient has subpericardial effusion. But what is this pericardial effusion? Congestive heart failure by itself can have pericardial effusion, especially when it occurs following pulmonary hypertension. This pericardial effusion is a bad prognostic sign. This pericardial effusion is due to high venous pressure and transudation into the pericardial cavity. I was called in to see this patient. I said, let us concentrate not only on the fluid, but look at the pericardium. That pericardium is not normal. That pericardium is thickened. It's vocals. Some areas are projecting into the pericardial cavity. And look at the pericardial fluid. That is not a clean transudate. It is obviously an exudate, indicating that there is a pericardial inflammation. It's not a passive transudate. This is an active, exudative pericarditis. And we have to look for reason for it. It's an exudative pericarditis, thickened pericardium, amorphous pericardial effusion in presence of severe pulmonary hypertension. This combination is not uncommon in all the dyscollagenesis. Unfortunately, this patient had progressive systemic sclerosis. Probably you may remember Sherlock Holmes wrote a short story about a family who was tracing one of the family members who was secreted away thinking it was leprosy, and he found out it was purely progressive systemic sclerosis and brought him back to the family. Progressive systemic sclerosis can have pulmonary hypertension with pericarditis and pericardial exudate. Let's look at some of the localized pericardial effusion. Look at this pericardial effusion, which is just anterior, and not behind the left ventricle. It is anteriorly and not behind the left ventricle. It's not moving. I'm sorry. Not only that, this pericardial effusion occurring anteriorly over the right ventricle has pressed down the right ventricle outflow tract, and you will find by the vertical line that outflow tract is collapsing in DAST. A localized pericardial effusion can produce tamponade. The signs of tamponade, this particular patient. This patient had mixed connective tissue disorder. I don't know why the loops are moving, but you can see the pericardial effusion around the right ventricle, not around the left ventricle, around the right ventricle. This anterior localized pericardial effusion is pressing on the RV outflow tract, producing collapse of the RV outflow tract around the RV with pericardial thickening. And we wanted to look at what's the myocardial function. And we checked with the strain imaging, and we found in the strain imaging there is significant loss of strain, mainly in the basal and mid segments. The apical segments are less involved, so there is definitely myocardial pathology with basal loss of strain. So we came to localized pericardial effusion with pericardial pathology. Involvement of the myocardium, as shown by strain imaging, localized pericardial effusion can produce signs of tamponade. And this patient had a mixed connective tissue disorder. As I stressed earlier, connective tissue disorders are one of the common phenomenon which produces pericardial inflammation, pericardial effusion. Let us move to chronic pericarditis. long history of intermittent chills and fever is cachexia. Often presents with ascites and dependent edema. Elevated GVP, phasic pericardial rub, often tuberculosis. 48-year-old businessman, febrile illness for 4 weeks, paradoxical pulse. Look at his pericardium. You look at the pericardium. There's a lot of exudate sticking onto the visceral pericardium. Can you see that? Lot of exudate sticking onto the visceral pericardium. And this could be very well demonstrated in MRT. Look at the thick visceral exudate in the visceral pericardium as well as the parietal pericardium. This is, when you look at it, you may think that this is a caseating material over the pericardium. This could well be demonstrated by MO. The pericardium is thickened. Visceral pericardium has a lot of exudate attached to it. Parietal pericardium has also a lot of exudate attached to it. And there's a good separation of parietal and visceral pericardium. The nominal amount of material in the pericardial cavity, thickened pericardium, thick exudate over visceral and parietal pericardium. And this is what we saw. If you look at the thick exudate sticking on, and this is basically we went to the mediastinal and subcarinal lymph nodes, and the moment you find the subcarinal lymph node of more than 2 centimeters, it's a sign of tuberculous pericarditis. This is a patient with tuberculous pericarditis moving on to a chronic pericarditis phase, or you may see acute inflammatory pericardial inflammation going into a chronic phase. Mostly tuberculous, less commonly mycotic infection. The sequence is recurrent pericarditis, chronic pericarditis, chronic effusive constrictive pericarditis, that's what we saw just now, chronic effusive constrictive pericarditis, and finally constrictive pericarditis. Let us see what's constrictive pericarditis. The heart is a structure surrounded by so much of fibrous tissue, caseating material, everything encased in that sheath in the CT scan. Constrictive pericarditis is a chronic inflammation of pericardium. Pericardial inflammation, chronic fibrotic scarring, obstructed cardiac filling, calcification, and the fix of pericardial cavity. That's what you see here. The whole heart is encased, and you'll find that in the angiogram, there's so much of separation between the epicardium and the pericardium. The whole pericardium is filled, as you saw in the echo, with caseating material and calcification of the pericardium. The final stage, end stage of many pericardial diseases, is what we are seeing in this picture. And some patients will find visceral and parietal pericardium being adherent. And once they go into constriction, there's a very interesting sign that we find. Look at the apical septum, look at the IV septum. There's a shuddering movement. The septal shudder, what is called the septal bound, is due to ventricle interdependence. Which ventricle fills fast and suddenly the septum will move to the opposite side, indicating that there's an early diastolic RV filling, suddenly moving the septum towards the LV, suddenly LV filling increases and comes backwards. Septal bound is an early diastolic movement of the interventricular septum towards the left ventricle, and suddenly it is reversing back. There are many signs you may find in patients with constrictive pericarditis. This is not for constrictive pericarditis. These are my patients with left ventricular failure. Left ventricular failure is diagnosed by looking at the E by E prime in the tissue Doppler. You find the E wave decreases as the cardiac failure worsens. So the E by E prime increases. E by E prime more than 15 indicates an elevated pressure, indicates an elevated endoscopic pressure. E by E prime 8 to 15 may to decide on the other side. Below 8 is normal. So rising epithelial endoscopic pressure increases the E by E. This phenomenon do not occur in constrictive pericarditis. Here is a patient whose endoscopic pressures are more or less equal in constrictive pericarditis. In constrictive pericarditis, E by E prime is inversely related to LA pressure. It is and either pulmonary capillary pressure or LA pressure in constrictive pericarditis. Look here. In this particular patient, E by E prime was 2.53. On CAT measurement, as we saw earlier, pulmonary capillary pressure was 32. Markedly elevated pulmonary capillary pressure, which is not reflected in E by E prime. With the fibrous thickened pericardium will not allow the lateral annulus or any annuli to move significantly. That's why the E by E prime actually decreases. The fibrous pericardium around limits the movement of the E by E prime, and that results in decreased E by E prime in spite of increased LA pressure and RA pressure. Similarly, this is the normal phenomenon. We find the medial tissue velocity as a configuration. So the lateral tissue velocity, as we find here, lateral tissue velocity is much more than the medial tissue velocity. The waves are much bigger. But this phenomenon is also altered. You find in patients with constrictive pericarditis, you find the medial velocity becomes much more than the lateral velocity. This is called annulus reversal. The lateral velocity is hampered, is limited, restricted by the infiltrating fibrosis from the pericardium. So lateral annulus movement is restricted. Lateral movement becomes smaller than the medial movement. It is called annulus reversal. The earlier E by E prime coming down in spite of high LV endoscopic pressure or LA pressure is called annulus paradoxus, a paradoxical phenomenon. This is called annulus reversal. These are all signs we may find in pericardial pathology in constrictive pericarditis. Earlier, all the clinicians used to call constrictive pericarditis as a sign of many diseases. Today, echocardiography is called. This is also a sign of many diseases. When patients with constrictive pericarditis, you may find some confusion about restriction versus constriction. Both results in heart failure. Myocardial heart failure, stiff non-compliant ventricular myocardium. That is in restricted cardiomyopathy. Pericardial heart failure, thickened non-compliant pericardium. Both affect ventricular filling. That's why the confusion is. Normal systolic function in normal systolic function in patients with constrictive pericarditis may help you, but in the early phase of restricted cardiomyopathy, that may not be helpful. Restricted cardiomyopathy is defined as an idiopathic or systemic myocardial disorder, characterized by restrictive filling, normal or reduced LV and RV volumes, and normal or nearly normal systolic RV and LV function. Restrictive filling pattern by stiff ventricle. Normal or reduced RV and LV volume. Normal or near normal LV and RV systolic function. Look here, you find the filling occurs in early diastole is immediately reduced by a rapid desodation. Most of the filling occurs later in diastole. This is what happens here. If a patient from atrial fibrillation, you may find a deepened plateau pattern. Here also, there's a deepened plateau pattern here, a deepened plateau pattern, and this is atrial fibrillation. This is a deepened plateau pattern, very characteristic of restricted cardiomyopathy. restrictive cardiomyopathy and constrictive pericarditis. Both may have large aches, both may have near normal ventricle. So much of it, so many etiological factors will help you to identify most of the patients with restrictive cardiomyopathy and separate it from constrictive pericarditis. If you diagnose with a clinical, ECG, brain scattering, echo Doppler, CT MRI, endomyocarditis. Even in the hands of the best clinicians and all the investigations, sometimes the different diagnosis is difficult. There are many instances where a thoracotomy was required for the final diagnosis, even in the best of hands. Restrictive cardiomyopathy, unfortunately, do not have any signs of inflammation on investigation or otherwise. Pericardial diseases have its own diagnostic signs. But look for it. If you search for it, you will never miss the pericardial disease. Thank you, ladies and gentlemen, for patient hearing of this lecture on pericardial diseases and echocardiography appreciation. And thank you for hosting this lecture. Thanks to Bangladesh Cardiac Society, my friend Majumdar, and others, please.
Thank you, sir. Thank you, Vijayaraghavan, sir. And these two legends, Dr. S.K. Parashar and Dr. Vijayaraghavan, sir, are teaching us echocardiography, the Bangladeshi cardiologists, for last 1 decade. Thank you very much for your contribution. We have got very few questions. In fact, we are almost 2 hours in our session. One of the question was, do you recommend using thrombolytic therapy in pericardial effusion, especially caseous intuition or like this?
We don't use thrombolytic therapy when there's a cerebral effusion cause. You may convert it into a tamponade.
Thank you, sir.
Professor Vijay.
Yeah.
Sir Vijay, can you off the screen share?
Yeah.
Can you stop sharing your screen?
Yeah. Let me try.
Yes, sir. We have got Professor Abdul Wadud Chaudhary, sir. Sir, do you have got any comment or question? Professor Abdul Wadud Chaudhary, sir.
Thank you. I was spellbound. The 2 lectures, in their different ways, are so mesmerizing. Dr. Parashar has shown, by only emphasizing on 2D and mostly 2D and MO, how to find out the most in acute coronary syndrome, in ischemic heart disease, without putting emphasis on strain and other things. By only using 2D, how much information you can get, he has shown that. And it's going to be very helpful for the clinicians. They are working in the ER. And Professor Vijayaraghavan is a legend into himself. Well, the pericardial disease, whenever I will now face a patient with pericarditis or pericardial effusion, his name will come into my mind. He has shown how we can think of the etiology, how can we think of the degree of problem that the patient is having, and what sort of treatment we can resolve. All these things, by non-invasive tests like echocardiography, you can assess. And this is wonderful. Thank you, Dr. Parashar. Thank you, Professor Vijayaraghavan.
Thank you, sir. We have got Dr. Khalid Mohsin, sir.
Thank you, Firoz.
Yes,
This is two very practically focused lectures without a lot of theoretical discussion. I have a question to Dr. Vijayaraghavan, that as the tubercular pericardial effusion is very common in this part of the world, can we start the therapy by looking at the echo itself, because many patients are not agreeable to pericardial aspiration and of adenosine deaminase? Can we go for a direct treatment by seeing the echo, or you want a confirmation by the other methods as well?
Prefer a CT scan also. The CT scan showing 2 centimeters in a lymph node is supposed to be diagnostic. It's a publication about 10 years back in British Heart Journal. So that's the only other investigation I would like to do. But the just like tuberculosis and other things could be done. But in addition, a CT scan that's just showing subcutaneous lymph node enlargement is very diagnostic.
Thank you.
Some diagnostic aspiration can be done because starting blindly anti-tubercular treatment, why not do a slightly diagnostic aspiration? Why not?
Patient objection. That's the main reason.
Sometimes the patients are not agreeable to aspiration actually.
Even in acute pericarditis, which goes on and on, we try a therapeutic trial of antituberculous drugs without even aspiration. But it's always preferable to a diagnostic aspiration. Look at the cells, the sugar content, proteins, all these things, and confirm the diagnosis before we exhibit antituberculous treatment. The physician and the patient will have more peace of mind.
Professor Raghavan, have you ever had a patient with sarcoidosis that mimics like tubercular effusion, but actually has sarcoidosis?
Pardon?
A patient with sarcoidosis that has massive pericardial effusion, just mimicking tubercular effusion. Have you had that experience?
Sarcoidosis did not produce I have not seen sarcoidosis massive effusion. It's more myocardial involvement plus more mediastinal glands. The accompanying signs usually help you to diagnose sarcoidosis. Multiple gland involvement plus myocardial involvement, systemic signs, and other signs will help you to diagnose sarcoidosis. But I agree, not always. Often, 2 things: a diagnostic tapping for fluid plus a pericard through the same route as you do diagnostic tapping. You can put in a bioptome and take a biopsy of the pericardium. These procedures will definitely differentiate between sarcoidosis and tuberculosis because treatment is radically different. In one, you bombard them with steroids. In another, steroids are hardly given now.
Thank you, sir. We have got Professor Razia Sultana Mahmood, madam. Are you with us? So, she left us. Professor Sufia Rahman, madam, can you hear us?
Sir, can I have a question?
Please.
To Professor Govindan Vijayaraghavan.
Yeah.
Sir, often we see some sort of abnormal movement of the interventricular septum.
Yeah.
Like the jerky septum, paradoxical septum, and also the septal bounce. How can these sorts of abnormal movement of the septum can be differentiated by echocardiography?
See, very, very important question. The septal bounce or the shuddering of the septum is an abrupt movement. It lasts only in the earliest part of diastole. Very abrupt movement. Paradoxical movement is a continuous phenomenon and far more common in any patient with pericardium, any opening of the pericardium postoperative. The shudder is a very specific sign, seen in 2D as well as in M-mode, and it's a very sharp, only in the early part of diastole. And the timing of this event definitely helps you to diagnose, differentiate between these two.
Jerky septum?
Pardon?
Jerky septum?
Which one?
Jerky septum?
Associated with LPPP.
Pardon?
Jerky septum of left bundle branch off.
I didn't understand.
So he says, what are the causes of a jerky interventricular septum?
Oh, yeah. See, it's classically this subtle shudder or that kind of movement classically occurs only in constrict pericarditis. It's been rarely observed in some patients with pericardial effusion of long standing. It depends upon the pressure on the heart and the interdependence of the ventricles that affects the hemodynamics. But classically, it occurs in constrict pericarditis. It's a diagnostic sign of constrict.
Once you read constrictive pericarditis, you have to demonstrate two things: exaggerated ventricular independence and dissociation between intrathoracic and intracardiac pressure. On these two, all the signs depend on constrictive pericarditis.
Thank you, sir.
Thank you, sir. Thank you. Professor Vijayaraghavan, madam, are you with us?
Yes.
Yes.
Good afternoon and assalamu alaikum to everybody. It's a very nice presentation, and after a long time I'm seeing both the legends. We have met a long time ago in India. So presentation was excellent, no doubt about it. As usual, you made the complex thing very simple. And thank you for sharing with all our colleagues here. Thank you again. Have a good time and good health. Thank you. I don't have any questions.
Thank you, ma'am.
Firoz, Professor
Sir.
Khandokar Kamrul Islam is there. Professor
Yes,
Khandokar come. You have to unmute. Kamrul bhai, unmute correct.
Thank you, sir. Both of the speakers nicely elaborated their lectures. I enjoy it and learn many things and how to manage chest pain in emergency. We always teach our fellows the echo finding is the first most characteristic for the diagnosis of ischemic heart disease. And we today we learned same things from that. One thing in this COVID situation, how we handle our patient in emergency room if comes with chest pain with unsuspected COVID. One question to Dr. Prakash.
See, what our policy is that you should avoid as much as possible a sort of a COVID echo, because there are certain guides. The Indian Academy of Echo and the CSI has made certain guidelines for doing an echo in COVID patients. So first of all, we should know if they are negative or not. The problem is some of us do an echo from the left side of the patient and the patient is facing towards the other side. So if there is no emergency, then I think there should be if it has to be done, then you have to have a proper PPE dress. Patient should be in full mask also, and normally it is recommended not to do a transesophageal echo in these cases because there is a lot of aerosol infection also. So because there are a lot of cardiology implications in these cases, our aim is to be as much as possible to avoid also, unless we know their COVID status also. That is but if one has to do it, then immediately you have to have a full dress, all precautions, clean your probe with a hypochlorite solution also, and have a good mask, and then do all the precautions what we have made in the guidelines. But generally we avoid it also. Can't hear you.
Thank you, sir. Professor Twinhock, madam, have you got any question or comment? Professor Twinhock, madam.
Actually, Firoz, somebody had put a question for Vijayaraghavan, which was not very simple question. That lady asked why E/E' ratio is decreased in constrictive pericarditis. Very simple question. So that was a question for you, but I think it missed somewhere.
I described that in detail.
Yeah.
That the annulus cannot move freely in constrictive pericarditis because the infiltration of the annulus by the pericardial tissue. That's why annular movement is markedly restricted in patients with constrictive pericarditis, so that E by E prime decreases rather than increases by the increasing LA pressure or LV endoscopic pressure. A particular patient has an LA pressure or LV endoscopic pressure of 32, but E by E prime was only 2.5. Annular movement are markedly restricted and do not follow the standard rules of annular movement in such patients.
Well, Vijay, I think I may be wrong, but what happens in constrictive pericarditis, most of the filling occurs in early diastole, before there is extraction. So, and the annular motion on the medial side, it is exaggerated in fact. Because there is a lot of vertical motion also. So I thought that because of rapid filling in the early diastole, the E wave is also increased, and at the same time, E prime is also increased because there is an exaggerated longitudinal motion because of rapid filling. And because the E prime is increased, so the E or E prime ratio is decreased. That was my feeling.
I thought that the rapid filling is so brief in many of these patients. The conplative pattern common for constrictive pericarditis as well as for restrictive cardiomyopathy, both in the final stages. I said another movement is restricted by
But if E prime is decreased, then E oblique E should increase rather than decreasing. If you say that E prime is decreased, then the E oblique E prime ratio should increase, not decrease.
I agree.
Thank you, sir. Professor Perinak, madam.
Good afternoon, everyone. Am I audible?
Yes, ma'am.
Nice to see your face after a long time. Yes.
Am I audible, sir?
Yeah, very much.
Yes, you are very much audible. Yes, ma'am. You are audible.
You are audible. Yes.
Can you hear me?
Yeah.
Yes, ma'am. We can hear you.
Now we cannot hear you.
Probably she has got some problem with her net. Professor Abdul Salam, sir, you have got any opinion?
Yeah. Thank you very
So
much.
thank you.
Hello, Firoz.
Uh,
Should I talk or madam should talk? Hello.
Hello.
Firoz, madam बोलबे आगे ना আমি বলবো?
স্যার আপনি বলেন ম্যাডামের মনে হয় সমস্যা হচ্ছে নেটওয়ার্ক।
স্যার সালাম বলেন ওখানে ইন্টারনেটের কথা। Abdullah Shafi Majumdar sir for organizing such a wonderful session in every Friday. I must express my thanks and gratitude to Professor S.K. Rashar as well as this Professor Raghavan sir. They are the legendary echocardiographer in the world as well. So I really enjoyed the lecture of Professor Rashar sir. Being a pediatric cardiologist, I could easily understood how we can early diagnose the acute coronary syndrome. It was so lucid and comprehensive to understand, and I really assimilate his lecture. Thank you, sir. God bless you. And regarding Professor Raghavan sir, some of his talks I could not follow because of sound problem, network problem. So, but I have a comment regarding the pericardial synthesis, particularly in pyopericardium. I put one question to him regarding a thick insufficient pyopericardium, when during pericardiosynthesis most of the fluid do not come in easily. So one of such cases we put streptokinase in interpericardium, and it lyses the thick fibrin threads, and it could easily move out the pericardial fluid. Do you have such experience, and do you practice routinely for such cases, and what is the outcome, sir?
We have not instilled any sterilization or anything to dissolve the fibrinous material in the pericardium. We have not done it so far.
Yes, sir. Well, we have some, we reviewed some literature. There are few reporting, and you can avoid the surgery, particularly in COVID situation. If you want to avoid, and you can approach through the ethical approach, not through the subsequent approach. It is very good. Procedure we can practice. This is my message. Thank you, sir.
Okay. When you find
Sir, it is wonderful and excellent lecture by two legends. Thank you, sir. But regarding the escape parachute, sir, it's a very good information for evaluation of the ischemic heart disease. Actually, very basic thing to systolic thickening of the myocardium. But it needs, I think, some eyeball training. But it can be done very easily in emergency room to diagnose the non-diagnostic enzyme or ECG changes, echo and ischemic events in emergency room. It's a very good technique, and that can be applied and followed by everyone. But it needs some knowledge and eyeball training. That's the important. Another thing is the endocardial movement. It is also the same message of the myocardial thickening. Less than 5 is hypokinetic and less than 2 is akinetic. So it's a very good and excellent lecture by S.K. Parashar sir. Many times I have heard his lecture and learned a lot. Another thing is the pericardial constrictive pericarditis. Always it's a confusion to all echocardiographists and cardiologists. Many of the times it makes confusion of the restrictive cardiomyopathy and constrictive cardiomyopathy. But one thing Vijay sir have mentioned that look for the pericardial pathology. That will distinguish between the two diseases. It's a very good and informative information. And I think it will help to every clinician and echocardiographer in their practical life. Another thing I want to mention regarding the hand grippings. Actually, Parashar, I am very much fan of hand gripping. Whenever I get in case of any valvular heart disease, I get any gradient that does not match with the valve area, then ask my patient to do hand gripping. Actually, what I do in my lab, I ask him, please vigorously contract the grip like this, continuously. And within 2 to 3 minutes, I get the results. Same also for ischemic heart disease.
If you have got what we do that in case you have got a treadmill if you have got a treadmill in the same echo lab, then we give the patient a mild exercise of mitral stenosis till they develop some dyspnea of 70% of the heart rate or so. If suppose the treadmill is not there, there used to be old method of patients sitting, lying, or there are certain balls or so, you take it in your hand, you go on pressing the heart-shaped ball and get, your main thing is to increase the stress or heart rate also. Increasing the heart rate will shorten the diastolic time interval and increase the gradient.
Yes, sir. So thank you, sir. Both the sir for excellent and brilliant deliberation and excellent information. Thank you.